We're going to talk about the esophageal tracheal Combitube, talk about indications, contraindications, the two sizes of the Combitube, and then insertion technique. We use the Combitube to help us with gastric distension. Anytime we do back valve mask ventilation, even if we do it really well, we end up with some air in the stomach. And the Combitube may help us in limiting the gastric insufflation. It's not going to prevent it, but it may help us manage that. The Combitube absolutely depends on proper placement and good cuff seals in order for it to be effective. Otherwise, we have more effective ventilation with simply a back valve mask. Combitube is not an absolute method to prevent aspiration. It will not absolutely seal the esophagus. Patients have vomited around the esophagus. But it is more effective than cricoid pressure or Selleck's maneuver. When endotracheal tube placement is not going to be available for a while and we have gastric distension, the Combitube may be a tool that helps us. Also, indications for insertion would be when your patient does not have a gag reflex. And there's no absolute measure with that until you place the Combitube. But we typically go with the plan that if the patient will accept an oral airway, then they can probably accept that Combitube without much problem. Contraindications, there's only two main categories. One is esophageal damage, in that rare case where you have a patient who has ingested a caustic poison or some caustic substance that has irritated the esophageal wall, or if the patient has esophageal cancer, or esophageal varices, which are varicose veins on the inside wall of the esophagus. Those are very easily damaged and will bleed tremendously. Life-threatening bleeding can be caused by those. The other is size, and we'll talk about size here in a second. The fire district and the university carry the larger of the two sizes, the 41 French, as you see in the top picture. Boone Hospital carries the smaller one, or the Combitube SA for small adult. And research has shown, several studies have looked at this in the operating room setting, and they found that the smaller tube is certainly adequate for patients probably up to 6'5", and that certainly is most of our patients. In the bottom row of pictures, you see the pilot balloons showing you the inflation pressure, and realize that if you're using the smaller Combitube, there are different inflation pressures there. I believe 80 millimeters and perhaps 12 on the number 2 port. So always read the pilot balloon before you inflate. And then the other two pictures reminding us that these won't fit people that are very small and have almost no neck, and they certainly won't fit patients that have long necks. Another piece that comes in the package with both size tubes is the emesis deflector. It's simply a plastic elbow, 90-degree elbow. It fits on that number 2 port because almost all the time your Combitube will be placed in the esophagus, which means that number 2 port, which opens to the end of the Combitube, is a direct conduit down the esophagus, and vomit will come up that tube very easily. So this deflector helps get that out of your way and off to the side. You want to use that deflector after you have verified placement and after you've ventilated, because you may, in rare cases, need that number 2 port for ventilation, and you don't want that elbow in your way. So leave it off until placement's been verified, and then insert it to help you manage the emesis that will definitely come up the tube. Insertion technique has a few simple steps. We need to pre-oxygenate our patients. Pre-oxygenating is not hyperventilating. So pre-oxygenation means that we're going to use a normal tidal volume at a normal rate. So bag mask ventilation at 10 times a minute with just enough air to make the chest rise, but as much oxygen as we can possibly flow. So this is a good time for us to turn up our O2 regulators all the way to the max, which is 25 liters. And some sources are even indicating that a nasal cannula from a second tank in the nose at, say, 12 to 15 liters, in addition to the O2 flowing to the back valve mask, is a good practice. You want to test the cuffs while pre-oxygenation is occurring. Test the cuffs on the Combitube, lube the distal tip, and then we're asking you to do the LIP maneuver, L-I-P-P maneuver, which was developed by a physician named Dr. Lip, and you touch the cuff to cuff. You take the distal cuff and you simply touch it to the proximal or the pharyngeal cuff, and that helps get proper curvature. If you look in the pictures, the top picture clearly shows that curvature is not anatomical. That's not the way patients typically are, and that's the way the Combitube comes from the package. So by doing this lip maneuver, touching cuff to cuff, you will get a much better curvature, much more anatomic curvature, makes the insertion a lot better. You want to do that cuff to cuff maneuver right before you place it, because the tube will tend to go back to its form that it had in the package. Another very key point is to place the head in neutral position. If you think about it, you'll be ventilating your patient in a head extended, sniffing position, and that is not a good position to place the Combitube. You want to place the Combitube with the head in a neutral position, so you'll need to move the head right before insertion. If you'll insert the Combitube along the tongue and follow the curvature of the tongue, you'll have better results. The tip of the tube tends to hit the back of the throat and makes it difficult. So we ask you to hold the tube in your hand with your fingers at the teeth marks as though you're holding a dart, and place the tube that way. Slide it along the tongue rather than along the back of the throat. Insert until the tube is placed where the teeth marks are at the teeth. This is another good reason to hold your fingers there, because your fingers will come right to the lips where you want to be. And then you quickly want to inflate both cuffs. Remember, you only have a maximum of 30 seconds by National Registry standards to not be ventilating. And so unless you leave your syringes attached, and unless you immediately inflate those cuffs and hang on to those syringes, you'll be taking longer than 30 seconds. So once you've inflated, inflate both cuffs, hang on to the syringes in case you need to make an adjustment we'll talk about here in a minute, and then ventilate through that number 1 port. That is almost always going to be the port that gives you chest rise. Always listen first over the epigastrium. We don't want to listen over the chest first. We want to know if we're in the stomach, because that's definitely where we don't want to put any excess air. So listen over the epigastrium while you ventilate through number 1, and that will usually be what works. The tip of the Combitube is going to rest in the esophagus almost all the time, and the air exits the Combitube when you ventilate through the number 1 port. It exits the Combitube through the holes that are between the cuffs. That's why we need a good cuff seal. And again, ventilation through that number 1 port is going to work for you at least 90% of the time. Some studies show as high as 98% of the time. So you will rarely need to use that number 2 port. But if your number 1 port's not giving you chest rise, then you want to switch quickly to that number 2 port. Listen over the epigastrium. If you hear air going in the stomach, you see stomach rising, you certainly don't want to put any more breaths in there. And you'd switch back to the number 1 port. And in this case, we're going to suggest that you deflate the cuffs and withdraw the Combitube from the mouth about an inch or so, and then inflate both cuffs again. This is probably going to happen to you in your smaller patients where the tube has just simply been placed too far down the esophagus, and as the air exits those holes, it's against the esophageal wall instead of right over the opening to the trachea where we want it. Last thing, placing your Combitube makes it almost impossible for ALS providers to place an ET tube without removing the Combitube. The ET tube is the king of the airway. That's the best tube. The Combitube is certainly not a replacement. It's not even a close second. And so use your judgment. Don't be in a hurry to place that Combitube, because it will essentially lock out the ALS providers from getting the patient the best airway. And in fact, they'll probably have to remove the Combitube, which produces vomiting almost every single time. So we hope this is a quick and helpful overview of the Combitube.